Welcome everyone for this webinar. So today we are going to talk about especially ALL and in the for adolescent and young adults. I'm here today with Anita from CCI Europe. So in case you do not know Anita, which adapt, probably Anita, you can say a few words about yourself before we give the floor to Andish, who is with us today. Is a pediatrician oncologist. Don't ask me to pronounce that second time. And he's also going to introduce himself. So maybe Anita, a few words, and then we can start with Andish.
Yeah, thank you, Samantha. I'm really happy that we have this joint webinar today because we do exchange a lot. My name is Anita Kindesberger. I'm living in Vienna. I'm the chair of CCI Europe, focusing more on children than on adolescents. That's why this relationship and collaboration with Alan is for us very important to know who is more focusing on young people if they are in need. So this is why we are looking forward to this webinar. And Vision, we are very happy that you are the one who is presenting this because you're really an expert, and thank you for this.
Yes, thank you, Samantha and Anita. I hope that everyone can hear me. Thanks for the nice words. Yes, I'm Andish. I'm a pediatric oncologist working in Vienna at the St. Anna Children's Hospital. And my field of interest is ALL and lymphoma. And I'm also treating not only children with ALL, but of course also adolescents and sometimes also young adults when the medical oncologists ask us as a pediatric hospital to take over the treatment. So today I'm going, as I said, to focus on ALL. I think we should be all aware of the fact that unfortunately data and literature on adolescents and young adults with ALL is limited, but during the last, I would say, 5 to 10 years, more data and literature is coming out, and we are learning more and more how to deal with this very specific age group. Of course, all of us who are somehow involved in the management of an adolescent or a young adult know that it is a challenge for both sides. So also not only for the pediatric oncologists, but also for the medical oncologists. I think when we talk about a specific age group, we should always think about the definition. What is the definition of an adolescent or a young adult? And when we go to the WHO, you can see here how the WHO at least defines adolescents and young adults. And as you can see here, adolescents are usually defined as patients from 10 to 19 years and young adults from 19 to 30 years. But when you then go to the medicine, to the literature, most papers, most books relate to adolescents when they are between 15 and 19 years of age. What we also know is for ALL that there is an age-dependent outcome. And the question is, what is the reason for these different outcomes? And here I have listed a few possible reasons to which I would like to refer during my presentation. We know that there are different biological subgroups. We know that there is a different response to treatment. We know that the treatment itself, which is the most important prognostic factor, let's say in oncology in general, plays a role. Treatment toxicity is a very important fact, and also, of course, socioeconomic reasons might play a role. These are data from the US, and here you can see when we talk about adolescents, so 15 to 19 years of age, ALL is only accounting for 6% of all cancers, while in childhood it accounts for 30% of all cancers. So in the adolescent age, lymphomas, so Hodgkin's disease and non-Hodgkin's lymphoma, if we put them together, are the most frequent cancer diagnosed. You can see the same in a different way of presentation, and you can see that ALL is not so common in the adolescent age as compared to the age of 0 to 15 years. And again, you can see that the lymphomas are the most frequent cancers, as well as, for example, germ cell tumors. You can also see in a third way of presentation how the relation between non-leukemia cancers and leukemia differs over the whole spectrum of childhood and adolescence. And you can see that especially in the adolescent age, the leukemia cases drop down, whereas non-leukemia cancers are dominating. I think, I suppose that most of you know that we usually separate ALL according to the immunophenotype. We have 85% of patients having B-cell precursor ALL and 15% TLL. But again, when we look at the complete spectrum of age from 0 to 18 years, you can see that the relative proportion of TLL is increasing. And this is important because we know that TLLs are more aggressive disorders, more often need high-risk therapy, more often need allogeneic stem cell transplantation first remission to be cured. When I started studying medicine or with my education as a pediatric oncologist, TLL was regarded as a group with a worse prognosis as compared to B-cell precursor ALL. Nowadays, this is not the case anymore. The prognosis is identical because we have learned that by intensifying therapy, TLLs and the prognosis can be improved. This is, I think, a very important slide, although it goes to the details. You can see the different age groups of ALL, and the different colors reflect different biological subtypes. And when we look at the Philadelphia chromosome-like or Philadelphia chromosome-positive ALLs, you see that their relative proportion increases with age. So in adulthood, Philadelphia chromosome-positive ALL is the most common biological subtype, whereas in childhood it is very rare. And we also see that, for example, for the MLL subtype, which is a gene usually associated with a worse prognosis, and we see that by increasing age, the proportion of this rearrangement also increases. And it is the contrast for the good risk genetics like ETV6-1X1, which was called TELA-ML1 before, and for the hyperdiploid ALLs. You see that by an increasing age, their relative proportion decreases. So we face in the adolescent and young adult age, usually the more aggressive biological subtypes, which of course need a more aggressive and intensive therapy. Here you can see a very busy slide, but just look at the subgroup of age above 15. We usually assess the response to treatment after 8 days of corticosteroid therapy, after 15 days of chemotherapy in the bone marrow, and after induction therapy. And you can see that in the highest age group, the proportion of patients responding worse is the highest. So this is another aspect we should always take into account when we talk about ALL in the adolescent and young adult group. Here you can see what we usually do when we treat ALL in Europe. At least in the childhood and adolescence field, we have 3 very big consortia in Europe. We have the so-called IOPFM ALL study group, including countries like Austria, Germany, Switzerland, Slovakia, Czech Republic, Italy, Israel, and Australia. Then we have a very big group, what we call all together, including UK, France, the Baltic countries, the Netherlands, Belgium, and so on. And then we have the ALIC intergroup, which is including Eastern Europe and South America. These three subgroups perform trials for primary ALL. They usually enroll 1,000 patients per year. And the general concept of the treatment is the same in all three consortia. And here you can see a basic cartoon demonstrating that we have an induction, we have a consolidation with protocol M and high-risk blocks, and we have a reinduction and then maintenance. A few patients of the high-risk group usually need allogeneic stem cell transplantation to be cured. And again, when we talk about age, here you can see the distribution of nearly 5,000 patients of a very recent trial of us. And you can see that the older the patients get, the higher their relative proportion in the high-risk group gets. So demonstrating unfavorable prognostic factors of the ALL. And we would then separate the high-risk group into a group who got chemotherapy or transplant. You can see the same trend. From the age of 10 years onwards, you see that the proportion of high-risk patients increases. So the oldest ones need the most intensive, the most dangerous, the most toxic treatment, including allotransplant. This is analysis I did myself for the AOPSM ALL 2000 group, published 2 years ago, where we looked at the outcome of the adolescents as compared to the younger patients. And the adolescents were defined as 15 to 17 years, and the comparator were the patients 10 to 15 years. You can see that there is a trend for a worse outcome concerning event-free survival and overall survival for the older ones. But when you look at the cartoon C, there's no difference in relapse. But when you look, and this is the most dramatic finding, is when you look at cartoon D, you can see that 7.4% of patients 15 to 17 years old died due to treatment-related mortality, which was more than twice as much as for the group of 10 to 15 years. So these patients are, although they need the higher intensity treatment, are the patients at the highest risk for treatment-related death. And what we are doing in our current trial, in the 2017 trial, is trying to replace the toxic chemotherapy by immunotherapy, by antibody-derived therapies. Here, I would like to show you also really interesting data, unpublished data on 4,000 patients of our recent trial, which was finished a few years ago, the 2009 trial. We had 4,000 patients. And here you can see the different phases of treatment. Protocol 1A is induction, and then we have the non-high-risk patients with non-induction therapy, and the high-risk group of the trial, post-induction. And you can very nicely see in green and lila that the proportion of life-threatening infections is the highest among the older patients, and it is very high among the patients above 15 years in the high-risk group. So very clear data demonstrating their risk. Another big problem that we also have with young adults and adolescents are fungal infections. And when we analyzed our 2009 trial, we were a little bit shocked when we saw that among the group of above 15 years, 17% had an invasive fungal infection. Of course, the number of patients is not so big in absolute numbers, but the proportion is very high. Now, a very problematic toxicity in ALL, especially for adolescents and young adults, as you can see now here on this slide. Again, more than 4,000 patients, 4.2% of patients developed an acute asparaginase-associated pancreatitis. You can see the high-risk group in the lower part of the slide, but the standard medium-risk group in the upper part. You can just see when these events occur, usually during induction, for the standard medium-risk group during reinduction, and for the high-risk group during the high-risk blocks. But again, when we look at these acute pancreatitis episodes, you can see a dramatic increase from the age of 10 years onwards, and you can see the very high proportion in the high-risk group for patients above 10 or even 15 years of age. And this picture, I think, is even more evident in young adults, and I'm often discussing with my friends, with the medical oncologists at the adult wards, how to deal with asparaginase, because they are so much afraid of this pancreatitis and hepatopathy and thromboembolism, and I can understand that. But the problem that we always have is these, as I showed before, are the patients with the prognostically unfavorable subgroups who need an intense therapy. But of course, this can also be achieved by other means than asparaginase. Here there comes the thromboembolic events. We are usually not so afraid of the thromboembolic events in childhood ALL because they are usually not life-threatening, and they usually occur in the brain as a sinus venous thrombosis. But usually patients recover from these events. But we see again that that from the age of 10, but especially in the age of 15 onwards, the risk is the highest for the non-high risk and high risk patients. So among more than 4,000 patients, the incidence is around 7.7%. Then hepatopathy, just one slide. Here you can also see that grade 4 hepatopathy occurs preferentially in the older patients, especially in the patients above 15 years of age. And on the right side of the cartoon, you can see that the risk is the highest at the beginning of the induction due to the steroids, and at the end of induction where steroids and asparaginase have been already given. Methotrexate intoxication. I think this is also something we are afraid of, although it is a very rare event, but it can be very problematic due to renal problems and also late effects concerning the bone marrow, the liver, and others. And what we found when we analyzed the data from Germany alone, that again, the adolescents have the highest risk for a methotrexate intoxication, so for a severe delayed elimination of methotrexate, and the risk was higher in the high-risk groups as compared to the non-high-risk groups. For example, a very practical point here, I usually try to avoid starting methotrexate on my ward in parallel of 2 or 3 patients in the adolescent age, because I know that there is a risk, and having in parallel 2 methotrexate intoxications can be, for example, very, very challenging for us as the treating team. Yes, I can skip this. Then we have when we talk about late effects, we have one very severe late effect, which is especially problematic in the adolescents. It is osteonecrosis. Osteonecrosis leads to a massive impairment of the quality of life in patients with ALL, and it is mostly due to the corticosteroids, but we know that asparaginase also plays a role. And here we can also see a clear association with the adolescent age, where it occurs in a high proportion of patients. And we also need to know that there is also an association with female gender. Many of the side effects I've talked about during the last few minutes are associated with asparaginase, but we know from a few studies listed here that truncation of a scattered asparaginase therapy is associated with a worse prognosis. But this is, of course, only true for those studies, those protocols who rely a lot on asparaginase. What are other problems with adolescents and young adults? And there are some data from US which I find personally very interesting. There's this gap of adolescence and adulthood with regard to an inclusion in cooperative trials. I think we all know that the success of pediatric oncology was due to the multinational cooperation, due to the inclusion of almost all patients into multinational, multi-center trials. This secures quality. And here there are data from US, which have been published many years ago in MPO, which show that the older the patient gets, the less are included in the US into cooperative trials. And this is also an explanation for their worse outcome. These are data from non-Hodgkin's lymphoma, again from the US, and you can see a very similar thing, namely the older the patient gets, especially then in the adolescence and young adulthood, you see the trial participation decreases. And this is, of course, also an explanation for the worse outcome. Also, again, data from the US, very interesting. How much survival rates changed from the 70s to the mid of the 90s. Perhaps it's a little bit old, but I think still interesting. And you can see dramatic improvement of survival rates, 31, 34, 38 for the younger age groups, but only 19% for the patients in the adolescence, mainly due to the fact that these patients have mostly not been included in trials where different questions were posed and outcome improved. Now we come to the last third of my presentation, namely to outcome. And I would like to mainly focus on a comparison with children and whether patients are treated on pediatric or adult protocols, and what the explanations are for the very interesting findings. I would like to start with a very famous publication from JCO, at that time published by André Baruchel from Paris, together with his medical oncologist friend Nicolas Boissel. And they decided to compare their adolescents and young adults who have been treated in the pediatric FRALE 93 protocol and in the adult LALA 94 protocol. And you can see the different characteristics, which are not important in detail. But the final outcome data, and they put all the patients into one database and analyzed them, was very impressive. You see that the patients who were treated, same age group, who were treated in the pediatric trial had a significantly better overall and event-free survival. And they tried to find out the reasons and what were the differences between the pediatric protocol and the adult protocol. In the pediatric protocol, there were more vincristine applications, more steroids, more asparaginase. What we also saw was that the interval between remission, at the end of remission induction, post-remission therapy was shorter. So we don't care so much about weekends and Christmas and birthday. We try to stick to the protocol, usually in the pediatric setting. And we, of course, saw a higher complete remission rate and less relapses. This was the first publication. There was also a very famous letter to the editor accompanying this JCO paper. And when they performed multivariable analysis to find prognostic factors, they found very clearly for the whole group, but in particular for the B-cell precursor ALL patients, that inclusion in the pediatric type of therapy, so in the FRALE 93 protocol, was significantly associated with a better outcome. Then a little bit later, or nearly at the same time, US data came out. And again, there were compared adolescents and young adults, 16 to 20 years of age, between two different trials, because some were treated according to the Children's Oncology Group trial, the CCG trial, and some according to the adult trials. And again, they found the same things, namely, if the adolescents and young adults are included in the pediatric trials, they have a better event-free survival and overall survival. And also they saw that the pediatric protocols use more vincristine, more steroids, more asparaginase, more and early intrathecal therapy, which is very important. And they produced also less CNS relapses. Then the Dutch, so data now again from Europe. We have in the Netherlands the DCOG trials, and we have the HOVON trials. And again, the authors sat together and decided to compare this age group on whether being treated in a pediatric trial or in an adult trial. And again, exactly the same results. Overall and event-free survival significantly better when these young adults and adolescents are treated in these trials. And they also tried to find out what could be the reasons, and they're listed here. Again, more vincristine, more steroids, more asparaginase, shorter intervals between the therapy elements, usage of a reinduction element. We know ALL cannot be cured without a reinduction, and they saw, of course, less relapses. Then also the Italian people, Carmelo Rizzari, who is the CCI president at the moment, also did an analysis here with regard to adolescents, not young adults, and Maria Testi published that in 2004, and they also found very similar results: higher remission rates, less relapses, better overall survival when adolescents are treated according to pediatric trials. And what they saw, that at least in Italy, no high-dose methotrexate and no reduction was used by the adult colleagues. And A.J. Vora, together with one of his colleagues, published also very similar results for the UK, where they showed that, again, event-free and overall survival was better when these patients were treated in the pediatric ALL trials. So now I come to an end of this presentation. I tried to give you a very short overview on what is known at the moment with regard to ALL in the adolescent age and young adult age. I think this is the cancer subtype where we have most of the data available on how to treat these patients and what are the reasons why they are doing worse than the others. And I would like to leave the rest of the time to a discussion and to your questions. I hope it was what you expected from me. I was not so sure, but I tried to give my best to give you an overview on this topic. Thanks a lot.
Samantha, do you want to jump in, or should I start? And these are brilliant. So I'm in the pediatric field, you know, we are never that intense, busy with everything what comes to results, or to really understand what does it mean for the further treatments in this age group. And we are, as you also know, we are focusing on this age group much more now, because we know that they haven't been in the focus so well as we also know. So for me, there is one question in the chat, but first of all, I would ask you, how is these results? They are showing very clear. It would be better to treat them with pediatric trials. How does the adult world react? So how does the oncologist react? And is there a changes? And because it's already there, what is the answer to this?
I think my personal experience and what I also know from my colleagues in Europe is that the medical oncologists are getting more and more open to these facts that I have shown. I think they have seen and learned that our protocols are doing better than those. And they are developing protocols, what they call pediatric inspired ALL protocols. They don't want to use the exact name of our protocols and trials, which I think is, of course, correct and right. But they are trying to develop pediatric inspired protocols where they try to rely on many of our components and our strategy. But of course, they try to also adapt according to the, let's say, comorbidities of their patients, which can be very different from ours. They're, for example, trying to use lesser dosages of asparaginase, as an example. But for example, even in Austria, now I've been contacted by the medical oncologists to meet regularly because we are going to have our new AOPFM 2025 protocol. And they would like to be informed from the beginning onwards, because some of them are thinking to also put their young adults into our trial. And this would be, for example, in Austria, a big shift of a paradigm, because this has never been the case.
No, this is okay.
We usually applied always for 0 to 18 years when we send our trials to the ethics and competent authorities. But for the next trial, although it will start in 2 or 3 years, I think we will broaden the age group. Or at least in Scandinavia, I know that they have the same protocol for 0 to 45 years of age. This is still in place in Scandinavia. So Sweden, Denmark, Norway, they are doing the same for a very broad age group. And I think we are on the right track to cooperate with each other and to find common protocols for the adolescents and young adults. So I'm very positive about this.
And is this also a politic, what is Europe-wide, or because you're talking about Austria, what is a big step forward to really that they want to be involved from the beginning? And do you see this also on the European level as well? Like,
yes, I think so. I think so, because when I, for example, look at the Altogether protocol, which is including many countries in Europe, I don't know now the exact number, but many countries have as an inclusion criteria a broader age group. So it's not stopping at 18 years, but I think in some countries it is 25, 30, or even 45, as it is in the Scandinavian countries. I think it's always the same. The people, who are taking care of ALL, they should be open and talk with each other and look at the facts, and not looking on their personal small experience that they might have. Because if you talk with the adult oncologist, they always tell you, I see 1 or 2 or 3 patients around 20 years of age per year. Why should this patient not be included then in our pediatric inspired or pediatric type protocol? And I think it always depends on the people, but my feeling is that in at least I know it from Western Europe, I don't know it from Eastern Europe, people are getting more open.
Yeah, it's very important for us. I mean, we as an NGO, we don't give advices. We always come to the pediatric oncologist if we get requests. But for the young people, this is different. They really approach Alan directly, for instance, and this is why I think this presentation is so important, to really know what would be the best in this age group. Yeah, so I think it is brilliant. But coming to the questions in the chat, as in the Karina is also online, and she is asking, hi, Andisha, thank you so much for this interesting presentation. I was wondering if there are any hypotheses as why females are more prone to osteonecrosis than men.
As far as I know, there is no clear explanation for this. We all suppose that some hormonal reasons may play a role, but a clear explanation does not exist for that. The association of female gender has also not been found consistently over all study groups. What has been found consistently over all trials and all study groups is the clear association with an age above 10, in particular above 15 years of age. The association with female gender has not been found by everyone. So honestly, I cannot answer your question, but we of course suppose that the hormones in a female patient may play here a role.
Okay. Samantha, is the second, do you want to present the second?
Anna, who is also, well, was still on the line. So excellent presentation, thank you. Are there any data about the prevalence of cancer predisposition syndromes in adolescents, young adults, sorry, with ALL?
Honestly, we have no, I can just speak for of course, the adolescent age. To be honest, we don't have yet a full knowledge about all the cancer predisposition syndromes in our patient cohorts. We are of course trying to assess them in our ongoing trial. But when you look at cancer predisposition syndromes, when you look at our retrospective data, cancer predisposition syndromes are not playing that very big role in ALL, although we know all about Li-Fraumeni syndrome and hypodiploid ALL or low hypodiploid ALL. The cancer predisposition syndromes seem to play much more a role, of course, in lymphoma, in non-Hodgkin's lymphoma, where we have very nice data or very good data about the subtypes of lymphoma and their associated cancer predisposition syndromes. So I think the most famous cancer predisposition syndrome in ALL is still constitutional trisomy 21, so the Down syndrome. Here, usually patients with Down, or children with Down syndrome usually develop ALL in school age, so not in the adolescent or young adult age. So they get their ALL usually around 6 to 10 years of age. So a little bit later than we usually see with ALL, but they get it not in the adolescent or young adult age. So we performed a very big analysis within the ALL BFM study group, and the proportion of cancer predisposition syndromes which were known was not so big. I hope this answers your question.
I would have another, because I'm always interested, what can, you showed us today very, I mean, I have to digest, I have to listen again, I have to be honest, because it was really something new for even I know, but there was a lot of new things in there. Maybe I missed it, but can you let us know why the TALL, what you have said, when you were educated, it was, but there was a lower rate of TALL, and now it's higher. Why is this? Is this the case?
I think what we have learned that TALL needs a slightly different approach than B-cell precursor ALL. So in general, we have ALL, 85% of the patients have B-cell precursor ALL, 15% have TLL. When I started with education, the prognosis of TLL was 10 to 15 to 20% worse. But during my education, lots of trials were ongoing, asking different questions in ALL. And what we learned from these trials was that TLLs, for example, have a massive benefit from dexamethasone as compared to prednisone. So we learned that with another type of corticosteroid, we could significantly improve prognosis. What we also learned, because TLLs respond not so rapid as B-cell precursor ALLs, that's why they get the more intense chemotherapy and even allotransplant. So we also saw during the last 10 to 15 years that by improving allotransplant, not losing patients anymore due to toxicity, improved outcome for TLL. So intensification of chemotherapy using dexamethasone instead of prednisone and improvement of allotransplant are the main reasons why TLLs are currently doing better than 20 years ago, and now exactly the same as B-cell precursor ALL.
Then maybe I misunderstood. I thought the incidence is higher. It's not, but that you treat it different, and that's why. Okay.
No, the incidence is not higher, but the proportion is higher in the older age groups. So you have more TLLs in the adolescent age than in the young. Younger.
Yeah, and another question for us. So on a NGO like us, yeah, so working together with the hematological field, hemato-oncological field, like we with Ellen. This result, is there anything what you, from your medical perspective, you would see as what we can do or support? Because what if we get a request like this, what would you suggest to do if a patient is coming to Ellen or to us? I know what I'm doing, and maybe some other. I don't want to be that rude because might know what you're doing, but also could we do some awareness, or is it too early, or is it not something what should be? So what do you think?
No, I think it's not too early to create awareness of this data, because some of these data are not so new. These are not results from yesterday or last year. These are results which are available now for a long time. And I think more results will be added during the next month or year or years, because many trials have closed now, already including the older patients in the pediatric trials. And I'm sure that the results will be the same. Although I also know unpublished data which have shown these very good results for the adolescents and young adults. So I think what you could do is to make people aware of these facts. These are facts. This is not a finding by chance or a finding only by one trial. This is a finding in a transatlantic way, because it's all the same in the US as in Europe. And I think people have the right for the best treatment possible. I think we all agree on that. And I think perhaps in countries where the cooperation between the medical oncologists and the pediatric oncologists is not that intense, you could really, I think, force people talking with each other and sitting together. As I did it now very recently with my Austrian colleagues, and it was a very positive meeting, and having there also patients and parents in such meetings would be extremely valuable, I think. So I think it's not too early to talk about this more and more, because in ALL, these are the facts.
Yeah, I think this is a very important message for us. Maybe we can have an exchange on this. I don't know, because we are, I don't want to say it's a privileged world, but it is like it is. And you mentioned it very clear why the results are so good, because of the good collaboration, multinational centered trials, but not only because of this. So yeah, from my side, I don't have any issue, because I also know how to to come back if I listened the second time to the presentation. Samantha, I don't know if you have any questions from the audience. There is no question.
I think, Anita, you are also aware of the fact that CCI has also a working group for adolescents and young adults, and next year we will also have a virtual course on the topic of AYA, and this will be led by Andrea Ferrari from Italy, and my friend from Ireland, Owen Smith.
Oh yeah, Owen Smith,
and they will both address leukemia, and they will address both leukemia and solid tumors. And I think we will, of course, promote this course, and you and your group, CCI Europe, Ellen, you're also invited to take part, to be in this course, to see what is the current knowledge on this topic. And of course, ALL is the best example, because most of the data comes at the moment from ALL.
Thank you for this, because I think I've forgotten about this. I know that it's ongoing, but Samantha, then we can have exchanges what is going on in our world, and then I think it would be a very good opportunity to take part, because then it's already a mixture between patient advocates and the medical team.
Yeah.
And I think what I forgot to say is, I think it may be possible that, of course, the medical oncologists, but also the patients themselves, are somehow afraid, because our treatment is so intense, and it is known that it is very toxic, and it may cause acute side effects, but perhaps also, of course, long-term side effects. What I have not done today, but I can offer to do it in another webinar if you wish, is to show you how the future of ALL therapy looks like. And this future is trying to replace the toxic chemotherapy by immunotherapy, which is, of course, very well known by the adult oncologists. They are very used to give antibody therapies, but we are implementing them into our ALL trials, where some important parts remain as they are, the chemotherapy parts, but we are replacing many parts also by antibody-directed therapies, thereby reducing their acute toxicity. So the treatments, I suppose, will get much easier for the patients than it is now the case. So this is something I could also, of course, share once with you. And
this is very great, because I have written down it during your presentation, because I'm interested how does the future look for the treatment, and I was almost sure that it will be changes, because we have heard, but I think this would be very interesting, because as you mentioned, the toxicity is so high for young and people, and as older they get. So I think this would be good. And is it already then included in the 20? Yeah?
It is already included in our ongoing trial, but here we are testing them in a randomized manner. But in the 2025 trial, it will even be a fixed part of the treatment, in particular the high-risk patients and so forth.
Yeah, this is very, very inspiring and also promising. Let's see. So I think it's for me it was really, really good. I think also I hope for all those who were attending today. 30 people were in the call. So, and we will promote and share this webinar with many others.
Yeah. I have a question, because we see in the adult setting that fertility preservation is a big issue. So in the survey that we have been running in leukemia, with more than 2,000 respondents, we have seen that the majority of the patients said that the fertility topic never came during discussions with their physicians before they were actually put on treatments. So, and now we are talking about, of course, young adults who have a life in front of them. So how do you manage these discussions? Is that something you really have in mind and make sure that you discuss with every patient and family? Or
yeah, I cannot speak for everyone, of course. I usually discuss it all the time at the diagnosis with the patient and the parents, because I know it is an issue. And what we at least know for the standard and medium risk ALL patients, that due to the cumulative dosages of the drugs, there seems not to be a massive impairment of fertility. It is perhaps different when we talk about the high-risk group, where patients may even have an indication for allotransplant, and we know for allotransplant that total body irradiation is the standard of care for conditioning. The problem with ALL is that you're sometimes under pressure to start the chemotherapy because patients may come with a high tumor load, and then you don't have the time for at least the female patients to go for a partial resection, let's say, of the ovaries, because you need to prepare them, you need to do the operation, and then to start the chemotherapy. You usually don't have the time for that, because then patients can get too ill. With male patients, you have, of course, different options. But the question with ALL is always, as it is a systemic disease, leukemia cells are everywhere, or whether we can be sure that when we collect spermia, that this is free of leukemia. So in ALL, it's to be honest sometimes problematic, but for the standard and medium risk group, we know that the fertility is not impaired. So I really try to calm the patients with respect to this issue.
Mm-hmm. Yeah, this is, of course, a big issue. Yeah. Yeah.
And with solid tumors, it's different. And with solid tumors, we have time. So we have time to even send the male patient twice for giving the spermia when it does not work for the first time, because we can wait until the first block, because usually the patients are not in a life-threatening situation. With female patients, we also have the time. But here it is, I think, even more important, because the cumulative dosages of drugs, of ifosfamide, cisplatin, are so high that they have a very high risk to become infertile. And that's why we take the time to go for this. And when we talk, for example, about Hodgkin's lymphoma, we have performed frontline therapies, replacing the gonadotrophic procarbazine by dacarbazine. We saw that the event-free survival of the Hodgkin's lymphoma is exactly the same, but that the patients, that the boys don't become sterile, and that we can avoid even how do you say it in English, premature menopause in the female patients. So I can mostly speak, of course, for the leukemia and lymphoma ward, and here Hodgkin's lymphoma is a very good example that we really focused on this issue in a frontline therapy trial, and were successful.
Might be a very broad question, but so do you see a difference in the way that young patients are dealing with the disease, and how the family is dealing with the disease compared to, well, let's say an adult setting, or with very young patients?
I can only speak, of course, for the adolescent age group who are at my hospital with their parents, as compared to the younger patients, to the children. Of course, the situation is completely different, because when an adolescent becomes critically ill, when he gets or she gets cancer, her whole life is destroyed, because they're used to go out with their friends. They're used to get more independent of their parents. They are finishing school, they are in front of a postgraduate education, whatever, or have already started with a job, and suddenly everything is stopped. And they have many problems which we don't see, of course, in the younger children. In particular, they lose their hairs, they look completely differently, so they cannot, they don't want to see their friends anymore, they cannot go on a party, they cannot go into a discotheque. They are suffering a lot from that. They are suffering that suddenly their parents are very close to them in a phase of their life when they wanted to get independent, doing their things alone. And I think it's completely different. And we also have, of course, the compliance problems with the adolescents, because in a 3-year-old girl or boy, the parents control all the oral intake, which is needed, chemotherapy needed at home, because not everything is done in the hospital. But for a parent of an adolescent, it is very difficult to control whether the patient is taking his oral chemotherapeutics or not. And sometimes we find out by chance or in another way that they haven't taken their drugs, and by that they are compromising their excellent prognosis. So then we have also the depressive reactions, which really need sometimes drugs and a psychiatrist to help us to deal with that. So many different problems as compared to the children. And as a physician, I have to deal in this situation with two people. I have to deal with the parents and the adolescent, because I cannot talk with the parent while the adolescent is sitting beside them. It's completely different when you have a 2-year-old girl. I usually talk just with the parents. So it's challenging. But these are just examples. I think we could talk about this, what you're asking, for an hour.
I think you said something that I knew already, but it's good to get your feedback. But I guess to extend to what you just said, probably it's also where we have a role as patient organization to play, because we have the national organizations in the countries, they have support groups, they have a buddy system, and this is where I think the medical community, so you as a physician, have also a role to play. And when you have such patients and you don't know in a way what to do or how to address them, it's also to say, okay, go and talk to that group. They have children in the same situation as you, and maybe it's nice that you two talk together, you know. Yeah. So I see that we also have a big role to play in that, and of course, as you said, the situation is different from a very young patient to an adolescent. But I guess this is what we see with adults anyway. They are looking for people to talk to, people who know what they are going through, and so I guess it would be the same with adolescents as well.
Yeah.
We see, unfortunately, that, and especially in acute leukemia, that patients are reaching out to us quite late in the process. So even if they need to speak to people, and even if they would like to speak to someone, they just don't know where to go or who to ask. So I think there's definitely room for improvement in the collaboration we have with you as physicians, with the physician community.
I think it would be very important that these people, or these patients, talk at the very beginning of their diagnosis and therapy. Yes. With the respective persons, so that they can get optimistic about their disease course and their outcome. And I think raising awareness is what you could do as Ellen and CCI Europe about these things.
Yeah, exactly. Yeah, so because it's an hour, thank you so much, really, that you prepared this presentation, that you are educating what is going on. I think it would be very interesting to have a view or to get more to know about the future of the treatments. But we stay in touch.
Yes.
And thank you. Have a very nice holiday with your kids. And we see each other soon, hopefully.
Yeah.
And
Good.
thank you, Samantha, for organizing this, because we would not have done that. So I think this is a very good start also to collaborate with the adult and world on our level.
No, you're welcome. So thanks for your time, Andish and Anita and people on the line. So you will be able to find the recording and the slides on the Alan website, and I'm pretty sure CCI is going to do the same. So you can watch the session again if you are like Anita and myself, or you can watch the session if you have missed the webinar. And I'm sure we are going to see Andish again in the near future, because now there's a lot of new topics coming into mind. So yeah, as Anita said, let's keep in touch. And until next time, take care, everyone. Stay safe. And we'll be in touch.
Great. Thank you, Anita. Thank you, Samantha. Ciao.
Thanks a lot. Bye.
Bye.
Bye.